So, dear colleagues, it's a great pleasure to be here again at Bus 17. I would like to send you the warmest greetings from Austria. And I will start with this lecture, which is going to be on the airway management in extreme situations. So I want first to say that I don't have any conflict of interest, financial conflicts of interest, besides being part in many societies and institutions which deal with extreme environment situations and situations where airway management may be difficult. So the extreme situations in airway management I want to touch upon are situations involving first the patient, then we'll talk about the environment, then the equipment, the skills of the airway manager and the team will also impact, and finally the ability to support a patient who has received airway management is also important and may also create an extreme situation. So let's talk about the first of the 5 situations. So first I would like to present you a patient after thyroidectomy who developed hematoma. So this patient had already surgery. He was in the post-operative recovery area, and his swallowing deteriorated, his neck extension increased, and the surgeon was busy with other things, so other patients, so he was not able to see him quickly. And only when we detected a severe increase in hoarseness and also neck distension, only then he accepted to see him and to revise the surgical wound. And that was the picture as we've seen when we performed laryngoscopy. Of course, the patient was well oxygenated. We used a video laryngoscope. And but as you see, there was no vision on the glottis, and that is the view as we have seen when the tube was inside. And this is now as the laryngoscope comes out, you see all this impinged bloody area with the epiglottis here, down here. So this is the epiglottis, and as you can understand, it was very difficult to recognize any structure at all. So that is why in this patient with a predicted anticipated difficult airway, we had the surgeons already on the bed on the operating theater ready for a coniotomy, and that's exactly what we did when after the second attempt we were still not able to visualize anything and not to be able to ventilate the patient. So we gave them a go, and fortunately they were able to dissect the trachea and insert the tube, over which we ventilated the patient before changing the tube to this position. So with good pre-oxygenation, the patient did not suffer any deoxygenation below 96% at all. Okay, so this is the view from the other side. So large cuts as you see, and again lots of blood. So fortunately the surgeons were on site. So patients can offer difficult situations because they have a difficult hereditary airway or acquired airway, as you have seen now. They may be not cooperative, but also very importantly, an airway management situation will also become difficult because the patient is unstable very often because he's hemodynamically unstable, and therefore treating a situation, so an airway situation plus a circulation C situation may be very difficult, and you should have enough staff. Otherwise, alone, you will run into major problems. So there are different guidelines you should be aware of for the management of difficult airways. In this case, the hematoma after thyroid surgery, published a few years ago. I will just show you a few signs which you should keep in mind. when the patient is in the post-operative periods. The DSATs, so with the DSATs in mind and checking them regularly, as you see here in the algorithm, you will detect airway narrowing earlier, and you will basically be able to surgically revise the patient earlier. So this is the algorithm which calls for early evaluation and detection, early call for help, and early evacuation and early airway management. I can't go into that now in detail, but you are very much invited to look in these guidelines closer. Also here you see the approach in figures, and in these figures you see exactly the steps you should take. And what they also say is that in every patient who has undergone a thyroid surgery procedure, there should be one set for opening the wound on site in the ward next to the patient's bed. So just in case you are not able to come down to the operating theater in time, you can evacuate the wound on site, which is better than losing the patient. A seminal paper was that one published by Thomas Heidecker on fiber optic intubation. You should look into that because, of course, with a difficult patient, fiber optic awake intubation is a gold standard. Every anesthetist should be able to perform. So then some new discussions which have not been solved so far. For instance, is an awake video laryngoscopy similarly effective and safe as a fiber optic awake intubation, or is an awake fiber optic and video laryngoscopy assisted tracheal intubation maybe even higher effective and also safe? So these questions have not been answered so far, but studies are going on. But of course, you need the equipment to do that. After the patient, there's the environment. So this is another patient I want to present to you. It's basically a very simple case which unfortunately happened recently in a hospital in our country. There a patient with potential difficult airway, obese, had been sedated for upper gastrointestinal tract endoscopy, and because sedation was not sufficient, they added the sedation, they topped it up, and finally the patient deoxygenated, he had to be tracheally intubated, he deteriorated with the SATs, and finally went into cardiac arrest, underwent CPR, and help was called in, but finally the patient died because he had been wrongly intubated esophageally. So you should be aware there are working places in your hospital where it's safer, which is the operating theater, versus less safe, which are not operating theater working places. And of course, you should consider performing potentially difficult airway management only in operating room areas where you have enough technical but also staff support. So these patients should be treated there to decrease the risk. There may be also other environments where the airway management may be difficult, out of hospital, in a cold weather area, and of course, unfortunately, like in Ukraine nowadays, in the war zone. Of course, here, just to keep it simple, don't do any complex airway management where it's not safe or where you don't have the sufficient equipment. So for the environment, this is another case from the Western Alps. Basically, a couple went into a snowstorm. She was very hypothermic, heart rate of 6. Only when the rescue team arrived, she had the hypothermic cardiac arrest, went into VF, and she had to undergo CPR with an AED only. She had to be extricated by foot before coming to the ambulance and helicopter. And finally, the patient underwent resuscitation, intermittent CPR because she had a hypothermic cardiac arrest. She then went to a center with ECMO, venous arterial ECMO. She was rewarmed because she was very cold, and she had uneventful neurological recovery. And this was possible although she was only intermittently, she received only intermittent CPR, because she was so cold with the 16.9 degrees that the heart could sustain occasional ventilation and occasional chest compressions, which were required while the patient had to be transported through the deep snow and over rock faces. So also this is a situation which is quite challenging. Then, after the patient and the difficult environment, there may be issues with equipment which can cause difficult airway or extreme airway management situations. So in this case, the patient was a motor driver with a complex facial trauma injury because the helmet was open. He had crashed into an obstacle, and this patient, when I saw him, he was in the rear of an ambulance, so a terrestrial ambulance, and I was the second doctor being called in. He was still oxygenating well, and the first physician anesthetist on site had planned to intubate him. We was just going to intubate him in the minute I came in, but he didn't. He hadn't given the anesthesia yet, so I questioned this first anesthetist whether this was a safe procedure, given that he was still oxygenating well and he had some massive mid-facial trauma. Finally, we decided not to intubate the patient, but to expedite the transport to the trauma center, which was just 10 flying minutes away. So this was with helicopter rescue. We brought him into the helicopter uneventfully. We gave him some oxygen. Saturation kept well, and when I transported the patient into the trauma center, there was a very cold reception. But the patient was still fine, and finally, after we came back to the helicopter base, I received a call from this admitting anesthetist, which gave me a very cold reception, and he thanked and said also sorry for the cold reception, because he thought that we had to intubate his patients pre-hospitally, but finally he said and he confirmed that it was a good idea not to do any airway management pre-hospitally, because they struggled in the hospital with the full team and the full equipment to establish a safe airway. So be aware that out-of-hospital equipment is very limited, and once you go in a patient which you can still keep safe with some oxygen for a certain time, you know the airway will obstruct at some point, but for a certain time it will be okay. Don't do too much outside, because if you induce anesthesia, you will lose the airway, and if you're not able to establish a safe airway and ventilate the patient, then he will die. And of course, with a ventilated patient, transport is also much more difficult. So postponing the intubation, as this study from Austria shows, is safe, and even in patients with major trauma, postponing the intubation is in some studies even considered better. There are studies which show that the mortality is lower, especially in patients who are unstable, hemodynamically unstable, because within anesthesia induction you may collapse the circulation, and the patient may also go into cardiac arrest. So don't induce anesthesia in patients with severe trauma if it is not absolutely necessary pre-hospitally. Ask yourself, what equipment do you have? How long is the way to the next center? What is the safest and the most reasonable option for the patient? The fourth topic I want to touch on is the skills of the airway manager. So when you look at this patient out of hospital, an unconscious 9-month-old infant with traumatic brain injury, ask yourself, are you in the red zone? Are you a novice in airway management, or are you a full-blown super expert who knows all the techniques and who has everything available? And there are lots of in-betweens, of course. And just to give you an idea, the European Resuscitation Guidelines 21, they say that rescues should only provide a high tracheal intubation if there's a intubation success rate over 95% within 2 attempts. That would still mean that 4 to 5 patients out of 100 would have not a safe airway within 2 attempts. And this is, as you know, for guidelines which are taking care of patients in cardiac arrest. And so if patients are spontaneously ventilating, the standard should be certainly much more higher than 95% of success rate within 2 attempts. And this in a small child with 9 months, in a toddler, may be very, very difficult. This is another patient with an angioedema from ACE inhibitor, antihypertensive drug a few years ago. We wanted to intubate this patient with awake fiber optic intubation, but of course because he basically had he was going to suffocate. That was why he was presenting to the hospital. We wanted to go through the oral cavity, but it was impossible. And through the nose was also impossible because he needed the nose for breathing. So with the ENT surgeon, we decided for some unorthodox approach, which was the rigid bronchoscopy. So we induced the patient with general anesthesia and under cricothyrotomy standby by the ENT surgeon. Also, the ENT surgeon performed rigid bronchoscopy, let's say besides this swollen tongue, and this was easily accessible with this rigid bronchoscope. So he put in the tube, and we had a safe airway, and we could ventilate the patient easily. So that is another very unorthodox approach, which when you know the guidelines well and you know your team well and you are very experienced, you can consider to go sometimes also other way, but you have to prove that this is that you are able to do that. Then of course you have to be aware where patients should be when you do airway management. So there are different options. You can look into this paper if you want to know more about ergonomics. And finally, I want just to talk about the ability to support the airway, because one thing is to provide airway management, but the other thing is to keep the airway intact, in place, and to provide ventilation. Because if you're in such an environment, excuse me, like here in the European Alps, it may be possible to provide airway management, but how will you get the patient down? Or in your environment in Ukraine, how will you get the patient to the next hospital? And this is why a group of different societies from Africa, Europe, and India stated that there are low resource settings, but not only in low resource countries, but also in mid and high level resource countries, like in war or natural catastrophes or remote areas. And one has to keep that in mind. So as you see here, this is the population density. This is with 1 or 100 persons per square kilometer in the Western European part. And if you look at the Alps, there are places in the valleys with higher, or around the high mountains with higher densities, the red one, and there are other places which are less densely populated. And you can look also on that on the European side, let's say like here in Svalbard, Spitsbergen, with very small places but avalanches with more fatalities also. So how do you provide airway management there, and how do you keep the patients ventilated? Do you have enough equipment, and do you have enough trucks? Do you have enough providers? So what's the best over here? This is from a competition, mountain uphill run with 2 fatalities from cold and other who collapsed because of the cold. And the same can be said for some mountain tours in Switzerland, where people died along the way because of cold weather, or also here with a China ultramarathon. 21 patients died in this ultramarathon, or again in the Swiss Alps, another 5 dead skiers from a cross trip over a few days. So how do you provide airway management there? Because in the cold environments, the plastic may not be compressible of the bags, tracheal tubes may not be flexible, the light may be too much during the day, or you may not have enough light during the night. The environment may be dangerous, and of course the equipment may be limited. and also staff will certainly be limited. But again, how do you transport these patients? And the same is also, of course, in the environment you are working in, unfortunately, in Ukraine. So there are challenges with helicopter rescue, but of course also with terrestrial rescue, and also here in this paper on multiple trauma management in mountain environments, but it's similar in remote environments and war environments. Providing oxygen is much more important than providing airway management. So these are the challenges. Sometimes there are patients with special cardiac arrest or pericardiac arrest circumstances, multiple casualty care. So how do you treat there? And the terrestrial, the terrain may be exposed and may be dangerous. And sometimes you have even to stop treatment and to stop also CPR. This is not a spectacular case. I just want to tell you briefly. So 12 boys a few years ago with the teacher were surprised during a cave excursion by rainfall. So they were stuck here in the end of the cave and they had to be brought out because with the rain, the water level in the cave was rising. So there was an urgency to get these people out. So this was 1 mile between where the kids were and where the safe place was. So at the end, the students were anesthetized and brought out by divers with 5 tight-fitting face masks. And they could all be rescued. But one diver died during this rescue accident because of some injuries and infection. So at that time, patients were anesthetized with ketamine and brought out as you see here. So very extreme airway management situation. So how do we perform airway management if the setting is well equipped, as we hope it is? So importantly, you should perform regular training. So in your hospital, you should have an airway lead, which is basically giving the tact along the year and providing training sessions, organizing them. It is recommended to perform regular asleep fiber optic intubations just to keep the technique and the skills with the anesthetist, but also within the team, let's say, up to date. And one thing which is also recommended is to perform difficult procedures, which may be helpful in extreme situations on a yearly basis, so that ideally all the team members, the anesthetist and also nurse teams, so they should train together, the nurses and the anesthetists. They should be skilled and confidential in these techniques like front of neck access, fiber optic intubation over the laryngeal mask, also extubation of the difficult airway, but also intraosseous access, because sometimes there's not only a AB problem but also a CA problem with no IV access. There are different models for simulation of coniotomy. This could be used, but some work also with swine necks. We use plastic models. And then there are also bronchoscopy trainers. They can also be built with random equipment, but this is the most high-end device on the market, and it gives you such views, and you can basically guide through these difficult airways and get some feedback. A very easy but important tool for people who are not skilled so much and who are not working so much together is to have some intubation checklists. They are very helpful. So before you go into the difficult airway or any airway which may then be difficult or extreme because you're less skilled, as we said before, just try to tick all the items, try to have a plan A, B, C, D, as you see here, and only then proceed with the anesthesia, induction and airway management. Giving a nasal cannula with oxygen, 8 liters, is a no desat technique. This is very safe for apneic oxygenation, which is very helpful. A nasal high flow oxygen is an even better technique, but that is rarely available in operating settings, but could be available in ICUs when you have to intubate a patient. And pre-oxygenation in the emergency patient is correlated with less hypoxemia, less cardiac arrest, and less aspiration, as you see here. Then, of course, you should also have an air management plan, as we said before. So there should be, according to Difficult Airway Society, a plan A, a plan B. So mask ventilation, supraglottic airway and endotracheal intubation, plan B, supraglottic airway device, plan C, back to mask ventilation with some additional tools and maneuvers, and plan D should then be the cricothyrotomy, ideally with the open surgical technique, which I will not touch here, but this is basically the equipment you will need, as you see here, to safely perform the airway access, as we showed in the first case at the beginning. So this is how our trolley looks like in the operating theater with the plan A, B, C, D, nicely basically signed up so that it's obvious. Intubating, introducing to introducer like the Frova catheter from Professor Frova is certainly helpful if it's difficult to access the glottis. Also intubation over the laryngeal mask as described here, also again by the Difficult Airway Society, is very helpful as a backup technique. So that should be also trained. And in the meantime, it's pretty obvious. Video laryngoscopy is certainly superior to direct laryngoscopy because the first attempt, pass attempt is higher. There are less complications. So this is certainly the default technique for the future video laryngoscopy, and it's only a question of financing, of course, and time until we'll get to that. So in real extreme situations, you should consider to keep the patient spontaneously ventilating, develop a plan which works. What are alternatives? Of course, include the patient to have a high compliance, so that's important. Then get the best team on site, so both for the airway but also for the surgical access, so the classical, that's very important. Then the more difficult the patient is and the more in extremis he is with regard to briefing, the less sedate him. So if he's really in extreme situation, don't sedate him at all, but provide local anesthesia, and then go for awake fiber optic intubation. Some may add video laryngoscopy. We don't do that, but consider to take large screens if they are available. So the screens where laparoscopy is done, for instance, that can also be connected to some fiber optic devices, and so we have a very good screen. So overall, we discussed extreme airway situations, management situations with regard to factors regarding the patient, the environment, the equipment, the skills of the airway management, the team, and also the ability to support the patient who has an airway. So plan accordingly and know the limits. Often, extreme situations may be preventable if you make the right prevention steps and optimize the situation. For instance, use peroxygenation. Sometimes they are unplanned, of course, but also the unplanned situations can be mitigated. Be prepared. That means be trained. Video laryngoscopy is certainly the technique which will come first in the future. And standardization is very important. Think about the plan A, B, C, D, which we discussed before. And of course, teamwork is very important. So keep your team informed. Communicate your plan A, B, C, D to the anesthesia team, to the nurses, but also to the surgeons. Do that in time and you will be successful. So that's all, and has been my pleasure. I hope you enjoyed this lecture. If you have any questions, please send me an email, and I'm happy to provide any information you need, and enjoy also my presentation. Thank you.